mobilization technique. So if I wanted to do a pelvis up technique, what is that going to produce in the lumbar spine on this side? Going to produce extension, right? So if I were to take her into a position where, let's say we're looking at that L3-4 again here, bias this for extension, bias here for extension with that vector, and then we're going to bias for extension below up to L4, straighten that bottom leg, stack the legs there, and then pelvis up is just pelvis going up.
Yeah.
Right, so that's all that is.
And that's if you're locking, you're producing extensions, you're locking.
Yeah. So I'm using my lock from below up into L4, and I'm using my lock from above down into L3, so that I can move L3-4. Okay, but pelvis up just refers to the force vector that I'm using to produce my mobilization coming from me moving the pelvis up.
This is exactly what we just did.
Yeah, pretty much. I mean, it's termed differently because we're talking about it being through the pelvis. So in general, a pelvis up technique would not have my hand down here on the spine itself. Pelvis up technique would have my hand here on the pelvis producing that vector. But yeah, it ends up being the same things that we've been doing.
So what's the difference for what I'm treating?
There isn't any.
Okay. It's just where your hand is and how I want to perform it, but you're treating the same thing.
Yeah, I'm treating an extension loss
Okay.
here and with this sort of thing. Pelvis up, pelvis down would just be a flexion moment.
Yep. No, I'm good now.
Got it, okay, cool. So fibular mechanics. So the fibula in relation to the tibia, right? When we're moving, it generally is either gonna produce a superior, inferior, posteromedial, or anterolateral glide. Okay, if I go up on my toes, we're gonna get an inferior glide with an anterolateral glide combination. If I go into a squat, we're gonna get a superior glide with a posteromedial combination. Okay? Assessment here, flip onto your back for me. This is one of the few areas that I will use positional testing consistently. Because what I want to do is I want to get the heels together, try and be as neutral as I can, and then I'm going to look at the front of the fibula for deviation forward or backward, like so, and then I'm going to get onto the top of the fibula, look for a deviation superior or inferior. And I can also look for those superior and inferior things down here at the base, the fibular face. Okay, so that's step one as far as kind of the examination process. We can have them do some active movement tests, right? We can have them standing and have them do rotations, standing rotations, where we're watching the fibula move relative to the tibial tuberosity. So if I stand here and I'm looking at my right fibular head and I rotate toward it, so if I rotate to the right, the fibula should relatively come closer, approximate toward the tibial tuberosity. If I rotate away from it, relatively those two things should get further apart. Okay, so that's looking at active movement for anterolateral or posteromedial moments. Okay, but then once I find that out, if I say, okay, you know, when I'm looking at it here, I've got a patient that looks like she's got a little bit forward position of the right fibular head. Problem is probably going to be on the right side if we're looking at this side here. Then I have to do a passive glide. Right, so I would get onto the fibular head here and I would say, okay, does that have an adequate posteromedial glide to it? And if it doesn't, I would assess for my infield. Does it feel like soft tissue, or does it feel like a subluxation, or does it feel muscular, which is kind of probably a random one that you'd have there, but I suppose it's possible. More than likely with this one, it's either going to be capsular or pathomechanical. Okay. Same thing if we have a superior or inferior deviation. we do our passive glide. So if we have an inferior deviation here, if she's looking too far forward, right, so too far anterior medial, what would we suspect would be the direction of the fibula, superior, inferior?
Inferior.
Inferior, yeah. So we'd expect it to be too low, so we'd come onto the base of the fibula and we'd look at how well does this glide superiorly. Okay, now if I'm dealing with a situation where I have both of these things at the same time, then we can do treatments to affect either one or both. Right, so if we had a situation, go flip on your side for me. If we had a situation where we needed, there you go, we needed to produce superior and anterolateral, then we'd come in and we'd do this pull cue motion here, like so. Or we
Your
could
bottom
do,
hand is on the inferior part of it.
yeah, I'm just kind of grasping the base of the fibula and trying to push superiorly with it, right? So the vector's here, and then we're gonna get behind that, we're gonna do that, so it's kind of this sort of moment, okay? Otherwise, we're just gonna do a percussion treatment here. So go ahead and flip on your back again. She looked like she was a little bit forward on this right side. I'm just gonna compare here a little bit. Yeah. And a little stiff there, aren't you? So percussion treatment, I would just get onto the front of the fibular head here, looking to push this posterior medial, and then I would produce a percussion, so I just thump it right here with my hand, just like that. We'll click as it does that, and then we'd reassess our glide. If we wanted to do a percussion treatment or a more direct treatment for anterolateral glide, we would actually get her into quadruped. Right, like so. So if it's this leg here, bring this back slightly. Because what we want to do is we want to follow the plane of the joint. And the plane of the joint is going to be relatively variable with its regard to the coronal and the sagittal planes. And so we'll have to find that, and we should have found that, relatively speaking, when we're doing our mobility testing. So we find that plane, get our thumb on the back side of the fibular head. We have to be cautious here not to create a Snell's sign, right? And so from here we could do either a percussion or we could do a direct thrust. Okay, that's pretty much the whole shebang there for the TIB FIB stuff. We can have a little pivoting moment at the fibular base. So basically, it's such a small articulation. We have the tibia here and we have the fibular base, and basically all it does is kind of just rocks back and forth like that. Very small amount of motion, but when you think about it from that perspective, you might think, well, if there's only a little bit of motion, that little bit of motion is probably important. Otherwise, it wouldn't move at all, right? Similar to our SI joints, right? It's like, well, we don't have a whole slew of excursion here through these joints, but what little movement is available is probably pretty important. Otherwise, it would just be a fused component, right? So we would just grab onto this and we just look at anterior posterior tilt, just kind of how that rocks around the tibia. I will say, in most cases, if we find some sort of restriction here, it's usually because it's tilted too far back and it needs to come forward. So a treatment technique for that would actually be on the belly. I'll show you guys on this foot here. So what I would do is I'd take this ipsilateral hand here, I'm going to get it behind the fibular base, I'm going to reinforce there on the with my other thumb, and then I'm going to block the tibia with these fingers. All right, so on the base there, blocking the tibia, and then it's just this sort of like little flicking type of motion. That just clicked actually. That's really the only thing that we have to worry about down here outside of mortise stability. Right, mortise stability is obviously a big one. Yeah, so nothing terribly complicated there, I don't think. Any questions? Jane, you good with that? Cover what you wanted?
Today? Yep.
Today? For now. Give me your home number, I'm gonna call you tonight. Yeah,